attended the past 3 webinar as well. It may be a little bit new for a couple of you, but those who have attended this first time, I would like to briefly, explain what the Mekong One Health Innovation Program is. Then I'll introduce today's speaker. Then the speakers today, she will give the talk. So Mekong One Health Innovation Program. This is U.S. Department of State, Bureau of East Asian and Pacific Affairs funded 3-year cooperative agreement. It has the main goal of creating a transnational network within Mekong region as well as beyond Mekong region, and using the network to connect with the U.S. researcher, One Health researcher and practitioner, and share the tools that have been developed and used in the U.S. and also learning from the Mekong region and do a kind of co-learning. So it has basically 3 components. The first one is the monthly webinar that we all have been attending today. And the second one is the short course, which we call Health Security, One Health and Zoonosis, that is upcoming from April 17 to 28. And this will be a 2-week course, 2 sessions each day. Then third program will be providing some research fund to select a proposal, a researcher based on the proposal, selection of the proposal submitted by the local Mekong researcher. So basically 3 countries that Mekong MOHIP is working at is Thailand, Laos, and Vietnam. We have with us a country coordinator in here, country advisor are also on board. We are very thankful to every one of you from the Mekong region and elsewhere, from wherever you have been joining this. This is a great privilege you having us with us today. So this said, if you have any questions about the MOHIP program, we'll be happy to explain you or provide you the information. I think you have the mohip@msu.edu email that you have received the registration confirmation that you can send your question to us using that in that email. This said, let me briefly introduce today's speaker. She has been with us, working with us for a long time, and I would like to especially acknowledge the support and advising of Dr. Wilkins. Dr. Melinda Wilkins is an associate professor in the Department of Veterinary Population Medicine at the College of Veterinary Medicine, University of Minnesota. She received her Doctor of Veterinary Medicine degree from Michigan State University in 1994, MPS from University of Illinois Springfield in 1999, and PhD in Large Animal Clinical Sciences, focusing on epidemiology from Michigan State University in 2008. She worked for USDA, APHIS, DS, veterinary medical officer, and in other positions, as well as CDC Center for Disease Control and Prevention, and the Michigan Department of Community Health prior to starting her academic career. She started teaching in the MPS program at MSU, then became the Doctor of Veterinary Medicine, became the Director of the MS in Food Safety Program before becoming regular faculty in the DBM program at MSU CVM, Michigan State University College of Veterinary Medicine. Her interests lie in quality instruction, infectious disease epidemiology, and surveillance. One Health, international health are her other interest area. Her expertise is in veterinary and human infectious disease epidemiology, veterinary preventive medicines, One Health, public health, global health, and liaison work with human and animal regulatory agencies. Dr. Wilkins teaches animal, human, and ecosystem health, zoonotic diseases, occupational health and regulatory medicines sections, and public health and community medicines, among others. She envisions our students to see themselves as One Health practitioner. So with these brief introductions, As you can see, she has several decades of experience working in One Health, public health, and veterinary medicines. So without further ado, I'd like to welcome and invite Dr. Wilkins for your presentation. And Dr. Wilkins, if we can have some time towards the end, or if you feel that if this is the time for asking requesting audiences for the question, you can stop anytime. If we also see some question in the chat box, we'll also allow you. And please, Mike is yours. Go ahead.
All right, thank you. It's an honor to be here, and thank you very much for the invitation and for a chance to share some of my knowledge, and I will learn from you as well. So I encourage you to go ahead and ask questions and make comments as you can. And I will share my screen. So hopefully you're seeing my screen now.
Yes.
Okay, just have to move the bar out of my way. Okay, so I think that was quite a long introduction, so I won't go on any more about that, but we'll go ahead and get started. Maybe. Okay, so I wanted to kind of just go over some different types of disease surveillance and then go over the importance of quality surveillance data if you're going to be using surveillance data for evidence-based decision making. And we'll talk about some of the strengths and weaknesses of surveillance data, the important role of surveillance data for zoonotic disease outbreak investigations, and then the necessity of coordination among human and animal health regulatory agencies, and certainly environmental agencies as well. Though with the focus on zoonotic disease, I kind of focused on human and animal health. So let's see. So how is surveillance defined? Most of the definitions you'll find come from the public health side, and those include the ongoing systematic collection, analysis, and interpretation of outcome-specific data for use in the planning, implementation, and evaluation of public health practice. That's a typical textbook definition. And another one is similar: ongoing systematic collection, analysis, and interpretation of health-related data, essential to planning, implementation, and evaluation of public health practice, closely integrated with timely dissemination of these data to those responsible for prevention and control. So that's a little bit more complete definition that also includes not just the collection of the data, but also the sharing of the data afterwards. Let's see, I'm trying to figure out how my slides are advancing, I think down here. So I also wanted to look up how animal agencies define surveillance. So according to the US Department of Agriculture, for the purposes of national animal health surveillance systems, animal health surveillance is defined as the ongoing systematic collection, collation, analysis, and interpretation of data and dissemination of information to those who need to know so that action can be taken. So these definitions are all quite similar. And there are certain keywords that you'll see in both types of definitions. It's a systematic collection, it's ongoing, and it includes analysis, interpretation, and then dissemination of the data, of the health-related data. And so all of this information is being collected, analyzed, interpreted, and it needs to be linked to public health practice or action of some sort to make the whole process relevant. And there are a lot of different ways public health and animal health surveillance data can be used. And we'll talk about this a little bit more. The actual goals and objectives of the surveillance systems will depend on why you want to build a system or maintain a system or expand a system. So you really you need to decide what your overall objectives are. And we'll talk about that a little bit later, because the objectives for human health and animal health can differ substantially. But the uses of public health data can be to identify patients or infected animals and their contacts, to detect epidemics or other health problems, even changes in health behaviors, to estimate the magnitude and the scope of the health problem or problems, to measure trends and characterize the disease, to monitor changes in infectious and environmental agents, to assess effectiveness of programs and control measures, and to develop hypotheses and stimulate research. So if you're trying to establish or expand your health surveillance programs, it's good to have justification. And these are all very good reasons to justify, why you would be perhaps seeking increased funding or expansion of existing surveillance systems, or even creating one. There are a lot of good uses for public health and animal health surveillance data. And I wanted to talk a little bit about different types of public health surveillance. And the two main categories are passive surveillance. And this is where you build a surveillance system and then it sort of runs automatically. And this is where you might have your healthcare providers or your veterinarians or animal health technicians or laboratories. They basically know that there's a list of diseases or diagnoses, and if they find one of those, they need to automatically report it to a regulatory agency. So this is it's fairly simple. Once you set up the system and train people, it's fairly inexpensive. There are some problems. It's limited by the incompleteness of reporting and variability of data quality. So some people will take this responsibility very seriously and report regularly and completely, and some people will not. So we have to be careful with passive surveillance and really train your reporters so that they become very consistently reporting. Active surveillance is usually where a health agency is very actively going out and contacting healthcare providers or veterinarians, and they're soliciting, they're asking for information. So it's very active in that you don't just wait for the information to be reported, you go out and seek it. You can generally get more complete reporting of conditions because often you would be talking to somebody on the phone or visiting their office or their hospital. It's usually used in conjunction with a very specific investigation. So maybe an unusual cluster of diseases or a sudden death of a herd of cattle. And it's too important to wait for passive surveillance. You would need to go out and actively investigate it. It's much more expensive. It takes a lot more time, effort, travel, and so on, but you get a lot better information. And I just want to briefly mention a few other types of public health or animal health surveillance. And this is called sentinel surveillance, where you would basically set up a small network of sites to report information to a central body. And this is generally where you might pick one or two clinics in each state or a particular geographic area within your country. And just to kind of get an idea of what's going on. You're not asking everyone to report, but you want one or two clinics from each province to be reporting on a regular basis. And it might be something like for influenza, where you don't want everybody to report every case of human influenza, but you want just enough information and samples to know what strains are circulating. And this can be set up as an active or a passive system. The other main category, and this is fairly new in the last 20 years or so, It's called syndromic surveillance, where instead of waiting for a laboratory confirmation of disease, you're trying to focus on clusters of symptoms that might make sense. So like syndromic surveillance would be a group of symptoms that make up a syndrome. So an example of this would be using data that is being collected for other reasons and harvesting that data and analyzing it to see if you can make it useful. So some examples would be working with hospitals. When people visit a hospital emergency department, they would have a chief complaint, why they're visiting the hospital. And that gets entered into a computer. Then you can capture that information and run it through algorithms to try to make sense of that data. So emergency departments would be a source of syndromic surveillance. Tracking over-the-counter medication sales is another option. Using poison control or nurse hotlines are some other examples. And if you have particular interest in this, this is kind of some newer ideas, and it only works somewhat well. It works well. Generally, the emergency department data works fairly well. The rest are probably not worth the investment. But before you build a surveillance system or expand one, there are a lot of steps and a lot of things to consider. So there's sort of a process to surveillance. So before you even start collecting data, you need to try to decide what is the overarching goal of the system that you're trying to build. And we'll talk about some of the differences between human and animal systems in a few more slides. You need to think about who's going to analyze the data and what methodology will they use. How often will the data be analyzed? You would hate to spend a lot of money making sure you get information reported quickly, but then not have a person who can actually analyze that data and make use of it. So data interpretation is closely coupled with data analysis. And basically, you need to figure out, again, how you're going to use the data and how are you going to interpret it. The longer you have a surveillance system in place and the more consistent the data reporting is, you create baseline levels of like what you expect. You expect a certain number of cases of each disease. And so once you have a reporting system established and it becomes stabilized, then you have your baseline. So then when you go to interpret data, it's much easier to see when there's an unusual elevation above your baseline, above what's expected. Or something like influenza, you might expect to see a seasonal increase every year, and that's what you expect to see. But if you were to see a sudden increase in a season where you don't expect it, then you would be concerned about it. So you need somebody who really understands the system and the data to interpret, usually looking for any significant or rapid increases or changes in the data that you were expecting. And then your data dissemination is a very important step, and it's one that is often overlooked, is that you need to close the circle. You're asking people to report all this information to you or to your agency, but then you need to get that information back to your reporters. So oftentimes this information might be put on the web, on the website for the agency. It can go out in health agency newsletters or alerts if there's a sudden increase. Surveillance summaries and reports, medical and epidemiologic journal articles, media releases, social media. So that information needs to go back to the reporters so that they feel like they are gaining something from their efforts. So you're asking them to report, and then you need to in turn give them a useful summary of that information, and that helps keep the information flowing. And then finally, you need to link all of this. The last step needs to be a link to an action of some sort. So again, the actions that you take will depend on your overall objectives. So if you're talking about zoonotic diseases, infectious diseases, generally you're going to be trying to have some sort of intervention step, maybe starting health education program. If it's a foodborne illness, you might be trying to find the source of the illness and pull it off the market. It might be a vaccination program you need to start. For animal diseases, it could be, again, vaccination programs. It might be changing some management issues to start, or some antibiotic treatments or something. So I wanted to kind of just circle back again to this, that, there are a lot of uses of public health surveillance. And so this needs to tie back to your overall objective. If your objective of building a system is to identify, detect outbreaks and, make good estimates of that, or is it a pretty well-established system and maybe you want to improve the quality so that you can start doing research based on it? So you, again, keep in mind the uses of the data so that you can build a system with your objectives in mind. So how do you actually know if your surveillance system is working and is it effective? There are good ways to evaluate your system. And I put a link in here. I think these slides will be distributed, but the CDC has very good guidelines for evaluating public health surveillance systems. And these will work very well for animal health or human health systems. And essentially, it takes you step by step through a process to evaluate your system and make sure it's addressing the original goals, and then helps you answer the question, is this surveillance system worth the money and the resources, the human resources of time and effort, is it worth it to keep the system going and continue investment in it? So these are some of the surveillance system attributes that you can evaluate, and it talks about, the guidelines will give you step by step how to evaluate these, but is it useful in actually accomplishing its objectives? How reliable are the data that are being collected? How complete and accurate are the data fields in the reports received? Are the reports completely filled out, or are there a lot of missing data? How quickly are reports received? And this is really one of the really critical issues, is how quickly are you getting the reports? Because if you get them, but it's too late to respond, then that's a problem. So again, it goes back to your objectives. And that's why there's been a lot of interest in coming up with some of these earlier acting surveillance systems. And we'll talk about that in a minute. How quickly can the system adapt to changes? If you have an emerging infection, how quickly can you add that to your list of reportable diseases for your surveillance system? Is it, if you need to change a case definition, is it fairly easy to do that? Is it flexible? And the system needs to be fairly simple to operate. If it's too complicated and it requires too much special training and expertise, then your likelihood of people continuing to use it will decrease. Is this surveillance system really stable, or does it break down and crash, and do you lose data? How sensitive is it? How well does it actually capture the cases that you're trying to capture? And of those that you are reporting or getting reported, do they actually meet the case definition? And then another good question is, how well is the system's representativeness? And this can be, for animals, it may be is it representing the entire country? Or are you getting a lot of reports from the Southeast, but very few reports from the Northwest? Is it actually representing all of the livestock in the country, or oversampling some and missing others? Is it representative for humans? Is it representative of all of your different geographic areas? Or is it capturing your minority populations as well as your majority human populations? Is it capturing young people as well as old people? So not just geographic representative, but also population representativeness. And then how easy is the system to operate? If it's pretty easy and pretty simple, then people will be likely to use it, that it will be acceptable to them. If it's too complicated, or if it's always breaking down, then your acceptability is low, and people are less likely to consistently report in. So those are sort of the 10 main ways to evaluate your surveillance system, and those guidelines walk you through each step. So here's where I wanted to sort of point out that the goals of health surveillance kind of differ a bit between public health and animal health. So for public health, the information can be used for health action by public health personnel, government leaders, and the public can even access this to guide public health policy and programs. Now for animal health, it can be very similar, but as veterinarians or animal health professionals, we tend to think about surveillance. We're looking for rapid detection of any introduced diseases, emerging issues, monitoring and providing actionable information for endemic disease, and then measuring regional prevalence of trade significant diseases. So that's the last line is, I think, an important difference, and I'll get into this in a little more detail. So similar, but different in that for animal health, you're really dealing with both economic issues as well as health issues. So just this is a quick picture, but it's really important to do everything you can to improve and maintain the quality of the data going into your surveillance systems. So this is just a saying that we have, is that if you put garbage into your system, you'll get garbage out of your system. So if you put quality in, you'll get quality out. Okay, this is a very busy slide, but I'm going to walk you through it. This is, I took a lot of epidemiology classes, and I did a PhD in epidemiology, and I often felt a little bit lost in terms of trying to figure out where I was, what I was learning, how it all fit together. So this is my attempt, and I use this for teaching epidemiology. And this is, I call it the roadmap of epidemiologic reasoning, or the big picture. So I don't know if you can see my mouse or not, but when I'm teaching, I take the star and I move it along the timeline based on what topics I'm teaching. So starting down here is, we're trying to answer a question about a disease. You know, what is going on? So do we even know how many cases of disease X that we have? And then once we know that we have a certain number of cases, who's getting sick? Where are they? When are they getting sick? So we're trying to answer some really basic questions. And this is the stage where we're doing descriptive epidemiology. So we're answering the question of who, where, when, or for animals, what kinds of animals, where, and when are they getting sick? Descriptive epidemiology, you're just trying to generate hypotheses. You're trying to figure out a little bit of what's going on. And at this stage of descriptive epi, the really basic study types, correlational or ecologic studies, where you maybe have a single case or a series of cases, or a cross-sectional survey type work. This is all falls under descriptive epi. The next step is to move on to analytic epi. So this is where you're testing your hypotheses that you generated. You're getting into more complicated study types where you have comparison groups. So you have your case control studies where you have cases and controls. You have your cohort where you have exposed and unexposed, and then the experimental studies all the way up to the fancy clinical designs. So this is where you're trying to determine the why. Is there an association between this outcome and this exposure, or this disease and this, this agent? But what I want to point out here is that the bedrock to both your descriptive and your analytic epi is your surveillance data. So without your quality surveillance data, without having a really good solid surveillance system, it makes doing even the most simple descriptive epi work challenging, and certainly your analytic epi is challenging as well. So that's why I'm pointing out bedrock of all of this is your surveillance data. And then the tool for all of this is your biostatistics and epidemiology. So then just quickly, the rest of this is, you know, if you have, you've done some hypothesis testing, you have a measure of association, you have a relative risk or risk ratio or an odds ratio. And then it is when you move on and evaluate for validity, looking at the role of chance, bias, confounding, effect modification. If your association still holds, is still strong, then you move on to evaluate for a causal relationship. And then that's when you get into your whole larger studies, groups of studies, and you look for statistical association, biologic plausibility, temporal association, consistency of finding, and your dose response. So the main point is that really to get started on your investigation, you need good surveillance. So another thing I want to point out is that really a lot of surveillance systems, if it's a laboratory-based reporting system or surveillance system, really what ends up being reported is only the very tip of the triangle. So if you start at the bottom down here, people would, this is your group of people who are exposed to something, or your group of animals who are exposed. And then of those who are exposed, a smaller percentage actually become ill. And then of the people or animals who are ill, only a certain percent, a smaller percent yet, will be offered or seek medical care. And then an even smaller percentage will have the correct specimen collected and then be sent to the correct laboratory and then be properly diagnosed or identified. So when you get to the very top here, where cases are reported into your public health surveillance system, you may actually only have data available for anywhere from 5 to 20% of all of the cases that actually exist in the population. So the more severe illness, the better reporting, because people are more likely to end up in the hospital where there's higher chance to have specimens collected and tested and reported. So whenever you're working with surveillance data, you need to understand that you're working with only a small percentage of the total that's going on in the population. So if you're trying to estimate burden of disease and you have 200 cases reported, you need to know that you could have 1,000 cases out there, but you're only aware of a small percentage of those. So that helps you with your projections for disease burden, whether it's in humans or animals. And then I took the pyramid, I turned it on the side and made it into a timeline, just so you would kind of get an idea of your laboratory-based reporting systems will take a little bit of time. And then I just dropped out the pyramid. And as an example, I use salmonella. So even in the US, and we have a pretty decent systems set up in the US, it can take anywhere from 2 to 4 weeks from exposure all the way through to reporting by the laboratory or to a local health department or federal health department. So there are some things you can do to speed up the process. If you have electronic disease surveillance systems versus paper, you can certainly speed up the process some. And so that just sort of gives you an idea that there's always going to be a time lag. So you want to keep this time lag as small as possible, because the longer you wait, the fewer options you have for trying to control an outbreak of disease. And again, sort of working with your reporters, whoever's reporting into your system, they need to know that they're going to receive good dissemination of information, but also they need to realize that they are helping to identify outbreaks and epidemics, that you can help them by giving them information on prevention or treatment. They can help target prevention programs, identify care needs, evaluate successive long-term control efforts. So maybe you have an animal disease in your national livestock population and you start a vaccination effort, and you can use your surveillance data to show that your prevalence and incidence are dropping over time as the vaccines roll out. And also that works for human diseases as well. And also to facilitate epidemiologic research and assist with national and international disease surveillance efforts. And in some cases, like in the United States, it's actually required by law. So if you can have it that certain professionals are required to report things because of their licensing, then it becomes mandated, and that definitely improves the quality of your data and the quality of your reporting. So do you have any questions at this point? Does anybody want to make any comments, or you just take a pause?
Don't see any questions on Q&A yet.
Okay, I'll keep going.
Sure, yeah.
All right. So if you're just in the stages of building or expanding your human health surveillance systems, a question might be, what diseases should we even include? What diseases should we make reportable, which means that they would end up in your health surveillance systems? So certainly there are diseases of international concern, and there are just a handful of those that are required to be reported to WHO. I think smallpox, polio, wild type polio, new variants or new subtypes of human influenza, and SARS is of international concern. And then there's sort of the public health emergency of international concern, which WHO can declare those emergencies. So everybody who's part of the United Nations is already reporting certain diseases. So everybody has some basic surveillance systems in place already. Generally, a country will choose their list of nationally notifiable diseases, or a term like that, based on what it is they're trying to track. So that will be up to generally your Ministry of Health will have sort of a minimal list, and then state level, provincial level, regional level, you may be able to add additional diseases that are relevant to you and your region. And basically what you're trying to determine is who has these diseases. And again, it's the descriptive epidemiology we talked about, by person, place, and time. How are they getting these diseases? How is it being transmitted? What is the source? If it's it looks like an outbreak, what is the source of the outbreak? And then what is the trend over time? Is it, is the incidence going up? Is it going down? Are interventions working? And then, how can we intervene or interrupt transmission? So that could be, maybe a food recall, a product recall, a vaccination campaign, health education efforts. But when we're talking about animal health surveillance systems, we have different federal agencies. So there are diseases of international concern that would be reportable to World Organization for Animal Health. And when we're talking about animal products, there's the Codex Alimentarius that would have certain reporting requirements. So again, in a similar way, diseases of national, regional, or local animal health concern. But generally, when you're talking about animal health and animal systems, they're going to be a more limited diagnostic capability in most countries. Certainly in the United States, that's true. There are fewer animal health laboratories, and funding for animal health testing is much more limited than for human health testing. And this is where the very different objectives come into play. I mean, when you're talking about animal health surveillance, you're talking about health issues, but you're also talking about economic issues. So the diseases that you might include in your animal health surveillance systems would be production type diseases. So these would be diseases that your producers are worried about or your industries are concerned about, that are reducing productivity of livestock. They would be diseases that, if they're present, could restrict animal movement. So those lists of diseases might be determined by your department or Ministry of Agriculture or Livestock. And a lot of those will be driven by who your trading partners are. If you're trying to move animals, or for food products, your Codex Alimentarius, a lot of the decision making for what animal health surveillance system diseases will be driven by economics and what your trading partners want or don't want. So just a little bit more about animals. So there are two different kinds of animal surveillance objectives. And one is that we've already kind of covered, is that to answer the question about the presence of disease. Do we have this disease? In what species? Where is it? How much of the disease do we have? Is it a big economic impact at, for individual producers, or at a national level? Is it impacting trade or export markets? But then if you've controlled the disease, you also have to do surveillance in order to prove that you are free from certain diseases. So this is actually much more difficult. To prove lack of disease is much harder. And it takes some different approaches and different techniques. And this is often required to open up and maintain your export markets to, for if you're trying to export to disease-free trading partners, you need to be continually proving absence of disease in your country. So I just kind of want to point that out, because the human health people generally aren't aware of this, unlike the animal health people. So it's always a kind of an interesting discussion. So animal health surveillance in the US. This is,
Ida, can
yeah.
I interrupt you? I think
Sure.
we have two questions maybe before we go to the US surveillance.
Okay.
Sure.
Sure.
I will read, for Kwan, I will read the question here. Is that okay?
Sure.
The first question is, what are your suggestions, if any, for increasing coordination between independent surveillance systems collecting the same type of data?
Yeah, that's a good question. I guess I would try to talk to the independent surveillance systems, see who's managing them, and see if they have similar objectives. Because if they have similar objectives, then it's much easier to get them to work together. if they have different objectives, then it's going to be more challenging. And generally, if it's a government agency that has that they're both collecting similar information and not sharing it, then that's a kind of a government. You can put pressure on those government agencies for if they're wasting funding. Or a better way to do it might be to show them how they could be saving money if they were to combine. My guess is if you have two independent surveillance systems collecting the same type of data, then it may be that there are restrictions in how the data can be shared between. It might be that they can't share between agencies, or they can't share identifiable health information or something. So in that situation, there probably can be some data use agreements put into place that would allow them to share information. So I think you just would have to really explore why they were set up separately. But my guess is you could save time and effort and money if you could figure that out. And I can see the second, I can see the second question here.
Oh,
Sorry, I didn't think I would be able to. How to set up a good surveillance system in developing country based on people education and source. I would say in that situation, since I'm not sure what country you're from, but I would find out who is collecting information that is being reported to WHO and who is collecting, if it's on the animal side, you would want to find out who is collecting the information that's being reported up to the World Organization of Animal Health. Because there are systems that are already in place in almost every country. And if you can find out who's managing that system that exists and then work with them to expand it, you know, to find out, even if you just add 1 or 2 diseases at a time, there's already something in place. It's just a matter of finding out who's, and it's probably going to be your Ministry of Health that is reporting to WHO, and your Ministry of either Agriculture or Livestock, and just start asking those questions. If it's a good system that's already in place, then just you can focus on just gradually expanding it, I think. Hopefully that kind of addresses those questions. A lot of it is just going to depend country to country, but so this is animal health surveillance in the US. And you can kind of read through this, but basically what I want to point out here is that partners work together to protect animal health, but animal health also is tied to national economic viability and to the food supply. So investing in animal health surveillance is actually investing in public health also as well. So that's kind of a good argument to help justify investment in animal health surveillance. That's one reason, is national viability and food supply. And there are a few more. And again, this is the sort of the focus on international trading partners that we talked about already. And another thing about animal health surveillance systems is that they're not all of the diseases that are included are going to be zoonotic diseases. Some are zoonotic and some are not. Some are more economic versus health related. So it's important to understand that difference. And I put in here just a few links about some of the animal surveillance resources. We talked a little bit already about the National Animal Health Surveillance System. This is a passive system. And then there's the National Animal Health Monitoring System. And this is an active system where they pick one segment of industry and do a really, actively go out and do on-farm visits and interviews and collect samples. And they just do one industry per year because it's very expensive. And National Animal Health Laboratory System. And then again, the WOHA, the World Organization for Animal Health, has the international standard setting for animal surveillance. And I put down below the links. So if you want to look, follow those links to get a better look at some of the examples. And then again, those are sort of at the national level. And in the US, each state can add additional diseases to the list and be required. So if there's something in Minnesota that Minnesotans are worried about, but nationally it's not of importance, we can add it to our own list and have all of our veterinarians and laboratories report just in Minnesota. So this is just sort of an example of some of the diseases that have to be reported in Minnesota, which is a little longer list than what has to be reported nationally. So when is One Health surveillance information sharing critical? Well, if it's a zoonotic disease, I would say always, but I wanted to give a few specific examples. So certainly, if you have a foodborne outbreak, and the outbreak, is of animal origin, that's really important time to be sharing information really with your partners. And these are just sort of some foodborne examples that are usually of animal origin. Specifically, is this a situation where there could be common exposure for both humans and animals? So that could be aflatoxin in corn or peanuts or something where humans might be exposed and animals. Or water is a very common source if there's a pathogen in the water. Or is it a common ingredient that could be in both human and animal foods? So that's when it's really important to be sharing your information, with your animal officials and your human health officials. Or when it's a really kind of a complicated problem like antimicrobial resistance, which is, complicated by use of antimicrobials in humans and in animals both. And then we have the opportunity where animals can be sentinels for humans. So again, this helps justify investment into animal surveillance systems, something like avian influenza or coronavirus. If you can control the disease while it's still in animal populations before it spills over into humans, that is a great justification for investment in animal health surveillance and prevention of human illness whenever possible. So I also just want to wrap up quickly with, just the tripartite definition of One Health. And the tripartite is FAO, OIE, which is now WOAH, and WHO, and then the United Nations environmental programs. So they got together and they put together high-level expert and to come up with a new definition of One Health. And this is their definition of One Health is as an integrated unifying approach that aims to substantially balance and optimize the health of people, animals, and ecosystems. So I like this because it talks about the health of humans. It differentiates between domestic and wild animals because those are very different animal populations, and as well as plants in the wider environment. So, and it talks about mobilizing multiple sectors, disciplines, and communities at varying levels of society to work together to foster well-being, tackle threats to health and ecosystems, while addressing all the collective need for clean water, energy, and air, safe and nutritious food, taking action on climate change, and contributing to sustainable development. So it's quite a long definition. So if you're like me, I do better with pictures. And this is sort of the typical image we see of One Health. So humans, animals, and the environment, multidisciplines working together. But their expanded picture includes working, locally, nationally, regionally, globally, including rural, urban, and mobile communities, and then also involving inclusivity, equity, and access. So combining that with our traditional One Health, you end up with healthier ecosystems, healthier animals, and healthier humans. So I do better with pictures than words sometimes. And then I think it's about 9:02. Do you want me to finish up, or should we just stop here and take some questions?
Let's take some questions.
Okay. I can stop sharing and
There was this one question in the chat which said, how can we manage global animal surveillance through WOA and WHO through the PHEM system? Some diseases are reported only by either WHO or WOA.
okay. So probably the systems would have different objectives, and most of those diseases, I guess the question is how many diseases overlap. So if there's a lot of overlap, then what you'll probably find is one system is reporting, say, avian influenza only in humans, and that might be going to WHO. But whereas the WOA animal disease system is probably collecting avian influenza isolates from other animals, not humans, and that's going to be going to WOA. But at the level of your government, before those reports go off to the international agencies, that's being collected somewhere in your own country. So that's at the level that you need to be working, is trying to find out, again, who's collecting that information and reporting it, and then trying to work with them to point out how that information needs to be captured and shared, before it leaves to go be reported to separate agencies. It can be combined, certainly within the country. And that is a area where it's going to require policy efforts, which is something I know that physicians and veterinarians don't like to do very much, but it is, really all of us can be policy advocates. So that's where it's really going to take, they may not know even, these agencies may not know what the other agencies are doing. So it might take somebody from the outside to help point that out to them and hopefully show some efficiencies.
Thank you, Dr. Wilkins. Do we have any other questions? I don't see any other questions in the Q&A or the chat.
All right, do you want me to do a couple more slides?
Sure, sure.
Okay, I'll screen share again. And so I kind of just wanted to point out that, up to 75% of emerging infectious diseases in humans are zoonotic. So really they're impacting both humans and animals. And I thought this was interesting that over the past two decades, we've experienced devastating outbreaks caused by a lot of diseases, including West Nile, H1N1, and Ebola. And early detection and response to pathogens with zoonotic potential while still in animals is essential. So this kind of goes back to the, can we be using animals as sentinels to prevent the spillover? And I think the answer is yes, but the question is how to do it and how to do it well. And I thought it was interesting in the United States, they did a big external review of our national capacity to rapidly identify and respond to emerging zoonosis and other One Health threats, and found several critical gaps. And I kind of want to point out that the lack of surveillance tools and strategies was one of the critical gaps, and then the inconsistent linkages between human and animal surveillance and lab systems. So 2 of the 3 critical gaps have to do with surveillance. So if you're struggling in your countries to connect these agencies and connect the data, we're struggling too. It's very, very difficult to do. And so any progress that you can make should be celebrated, because it's really tough because of the way systems are set up. And in 2017, there was a One Health zoonotic disease prioritization workshop, and probably several of your countries have gone through this prioritization process also. And I thought it was interesting that coronavirus was the 5th on the list of diseases until it became number 1 with the big pandemic in 2019. But it was not detected in animals until it was well established in humans. We missed a chance for surveillance in containment in the animal populations, which left public health authorities with extremely limited and largely ineffective options for controlling the initial spread. Eventually, some antivirals and vaccines were developed, but so again, in the US, we tend to be very reactive to problems and not very good at preventing them. So reactively, Congress provided USDA with $30 million to conduct and monitoring and surveillance of susceptible animals to SARS. So very after the fact, but it's better than nothing. And the American Rescue Plan through USDA developed a strategic framework to build One Health capacity and improve the country's ability to prevent, detect, report, and respond to SARS. And you don't have to read this, but what I just wanted to point out, this is sort of the strategy. And but what I specifically wanted to point out is how often surveillance is in here. So improving additional capacity in One Health and multidisciplinary surveillance here, support and contribute to global surveillance and early warning. We have strengthened surveillance tools, advanced data management reporting and the exchange of information, and then engage One Health partners to use surveillance data. So as you can see, sort of the strategic plan for SARS and really any infectious disease is really surveillance is, again, it's that bedrock. So I just wanted to kind of leave you with, to think about where in this process of collecting data, analyzing, interpreting, disseminating it, where can you create linkages? Can you maybe start talking at the laboratory level? Could one laboratory start sharing information, from the vet lab to the public health lab and back? Can human health providers share information with veterinarians? Can veterinarians share their information with human health? Or can the sharing happen at the ministry level? And your ability to share information is going to depend on your local and national regulations, but really it's going to be a grassroots effort. We're going to have to start pushing probably more from the bottom up to make some of these changes happen. So I just encourage you to really become an advocate for information sharing. And again, the reason for collecting, analyzing, and disseminating information on a disease is to control that disease. So collection and analysis shouldn't be allowed to consume resources if action doesn't follow. So again, we don't want to collect information just to collect it. We want to collect it so that we can act on it and prevent or detect or respond to situations. So that's what I have.
Thank you, Dr. Wilkins.
Mm-hmm.
That was a very informative talk, and with some quite surprising facts, including that SARS was 5th on the list of prioritization list. We have one more question in the Q&A. What types of wildlife and zoonotic disease surveillance are you aware of domestically and on the international level? Is it mostly free-ranging or captive? Anything from import-export?
Oh, wildlife. It's a good question. In the US, we are tracking chronic wasting disease in our white-tailed deer population and some other wildlife, and that's a prion disease, similar to scrapie in sheep or bovine spongiform encephalopathy in cattle. So we are tracking that in our farmed cervidae as well as wildlife. We do track in wild pigs. We're tracking for production diseases like pseudorabies, brucellosis, which is also zoonotic. We're also looking for tuberculosis in deer populations. There's a lot of monitoring in wild birds for avian influenza viruses, of course, and we are having quite an outbreak of high path avian influenza in the US last year. Those I think are the big ones. I'm sure I'm missing some, but in certain aquatic species as well, we would be looking for certain diseases in wild caught fish or farmed fish and animals as well. So that's kind of what we're doing domestically. I'm sure we're looking at ticks for tick-borne diseases, mosquito-borne diseases, stuff like that. So there's quite a bit of that. And that is going to depend on the agency, but we have a US Fish and Wildlife, and then each state also has wildlife agencies as well to track more locally what's going on.
Thank you.
Yeah. Mm-hmm.
I see that there's a question from Dr. Songdian Moonsum. She is our country coordinator for Thailand.
Mm-hmm.
Dr. Songdian, would you want to ask the question yourself and also briefly give remarks on Thailand's, One Health surveillance system?
Okay, thank you very much. And thank you for wonderful talks today about the surveillance system. And my question is, I saw that you mentioned about the One Health surveillance, right? From your perspective, what is the difference between the One Health surveillance and the one, what we call the epidemiological surveillance or conventional surveillance? Yeah, that is my question.
Okay. I would actually say that One Health surveillance isn't necessarily different than conventional surveillance. I think what makes it One Health is the ability to share information between the conventional surveillance systems. So I don't think you would need a new or different system, for animal health and human health. What you would need is to build linkages between the two, and then together they would be a One Health surveillance system. Does that make sense? It's the difficulty in sharing information in a timely manner that makes conventional surveillance systems not as useful as they could be, I think.
Yeah, thank you very much for your answer. I think that is makes sense, right? It's very makes sense that so because it's not something new. We don't expect something new, that more something that more integrated, right?
Yes.
Or the holistic one, and that is. And funny, you asked me to give the speed also, right? Right, point of views of the Thailand, right?
Yes, please. If you could just tell us a bit about Thailand's surveillance system, that would be nice.
I think that Thailand, right, because One Health approach had been integrated into the what we call public health practice and public health policy in Thailand. I think that since year 2000. Maybe 16, when we have the memorandum of the understanding on the One Health initiative to achieve health security in Thai society, right? At the time, the Thailand bring had brought the sector, right, from the at least three ministry, right? One is the public health, another one is the agriculture and cooperative. That is like a take care the what do you call Department of the Livestock Development, Animal Health, right? That, and another one is about the environment, that from Natural Resource and Environment, right? Ministry, and then they formulate some operational plan on the surveillance, right? And more integrative surveillance system, especially for the human and animal health, right? And but the efforts will be more on integrate the data from the environmental health, right? That, and I think that one thing that Thailand would like to achieve, right, is how to share, how to integrate and utilize the data that what we call is a real one health, that is from the data that analyze from the human, animal, and environment together, right? And that data sharing is supposed to happen across the sector of the multi-ministry, right? Those are the things that Thailand would like to achieve in the next few years. That's all from my side.
Thank you, Dr. Songdian. I see no further questions, and thank you, Dr. Wilkins. I would request Dr. Ching to wrap up and summarize.
Thank you. Excellent questions.
Thank you so much for this excellent presentation. This is so relevant. Thank you for everybody to be at our webinar today. You raised great questions. I just want to encourage you to know in our incoming webinars to be more engaged and to raise your questions. Don't be shy. You can type few words. We probably can understand what you want to say. And also, we are sending more a reminder for, to follow up, and we will send a survey. Please respond to the survey. We really want to learn from you that we can provide and offer more support. And I hope today's webinar gave you some knowledge and also help you to think and maybe work within your system to help build up a better surveillance systems in your community or in your country or in your work. And we will send our the fifth webinar will be in March, early March. We will send invite to everyone who attended and who registered today's seminar webinar very soon. So until next time, have a great day and great evening. Please send us emails if you want to raise more questions or need follow-up, whatever, at mohip@msu.edu.
Good night.
Bye, everyone. Thank you.
Bye-bye.
Great to see
Thanks,
you.
everyone. Bye.
Dr. Wilkins, thank you so much.
My
Thank you so
pleasure.
much for
Thank
your
you.
time. Yeah.
Good to see you, Dr. Wilkins. Bye.
You too. Bye-bye.
Hi, Sangdian, Thira Kamal.
Yes,
See
bye-bye.
you
Thank you
soon
very
again.
much.
Thank you,
Yeah.
Sanjan and Dean. Yeah. Mhm.